Is my sound clear?
Yes, because simultaneous valve.
Yeah. So could it be pulmonary?
Yeah.
Yeah, because the pulmonary valve is also similar, but this is aortic and not pulmonary. So can you tell me why I'm so affirmative about that?
Coronary sinus.
Yeah, the coronary sinus, the coronary ostia. You see, these are the coronary ostia. Okay, probably this is the right and this is the left. Okay, coronary ostium, which is lacking in the pulmonary artery. And the other thing is that, you know, anatomically, the RVOT and the pulmonary valve is different than the LVOT and the pulmonary valve. And the tricuspid relationship with the pulmonary valve is not as mitral valve and aortic valve. The mitral and aortic valve tends to be anatomically connected, but tricuspid and pulmonary are not anatomically connected. There is an infundibulum and RVOT which isolate the pulmonary valve from the tricuspid valve, but that's not the case with aorta and mitral. They have a continuity. This continuity is called aortomitral cushion or curtain, this part. Okay, or sometimes they call it intervalvular fibrosa because it's between two valves and it's a fibrous tissue. And it's important because abscesses has predilection to this special area, you know, so they get the abscess get formed in this area, which can be destroyed, which can lead to fistula formation and all of that. Like in this case, there is an abscess formation and probably a perforation of the leaflet, like you see here, and probably fistula formation between the aorta and the right atrium. Okay. And you remember we said that the ECG is playing a pivotal role whenever we have aortic valve vegetation. I'm trying to advance the message everywhere I talk about the topic of infective endocarditis. If we have aortic valve endocarditis, I think doing daily ECG is important, because, you know, if you get blocks, okay, that might indicate abscess formation. You know, if you have vegetation here, this vegetation can extend periannularly and affect this area, which can compress also on the conduction system. It can compress on the conduction system, and you might end up having some ECG blocks. And believe it or not, sometimes the ECG changes precedes a full-blown abscess formation by echo. So when you do echo, even TE, you might just appreciate induration kind of, or phlegmon. You know, the abscess, what we see in TE is not that florid cavitation and necrosis, which nobody can miss. There is a precursor of abscess formation before abscess. That stage is called phlegmon. In phlegmon, there is just thickening and induration, edematous area, which we can easily miss, but it can be compressive and can lead to ECG changes. So ECG changes appear early at the stage of phlegmon. That's why ECG is sensitive, actually, for root abscesses and aortic valve abscesses. Okay? Yes. Okay. And you remember we said the predisposing condition to infective endocarditis is basically two. You remember these two, which are just to refresh your memory, we said that infective endocarditis requires two main prerequisites. Two is
structure of the abnormal valve and bacteremia.
Very good, thank you so much. That's it. Abnormal valve and bacteremia. Okay. Yeah, because abnormal valve is more likely to trap and seeds in bacteria that goes in the bloodstream. And you need bacteria of any kind, can be from dental work, can be from somewhere else. Okay, that's why it's so unlikely to find infective endocarditis affecting a normal native valve. It's either prosthetic valve or abnormal native valve. And we said the predictors of embolization are, just to refresh your memory again, just to remind you again, we said there are some predictor relating which valve, which cusp, the size, the mobility. So let's do it again. So what are the predictors?
Large
Mitral more than aortic.
mobile vegetation.
Anterior leaflet.
Yes, mitral more than aortic. Anterior mitral leaflet more than the posterior mitral leaflet. And
Size of the vegetation.
sorry?
Size of vegetation.
Size of vegetation. If you are talking about 0.8 centimeter or 1 centimeter, yeah, mobility of the vegetation and the microbiology of the vegetation itself. And if you are dealing with a virulent organism, the likelihood of embolization is more. Okay. And we also said that infective endocarditis is really a challenging disease in terms of diagnosis and in terms of management. That's why there is advocacy in the guidelines to establish multidisciplinary team or infective endocarditis team, which is basically a multidisciplinary team, include diagnosticians and cardiologist and cardiac surgeon and ID physician, you know, because sometimes you fail to sort out the diagnosis at basic level, which is culture and echo. So you need some time to go for PET scan, CT PET, metabolic PET, white blood cell count, white blood cell, scanning stuff. Yeah, very complex kind of workup sometimes. Okay. And even the surgery itself needs a special expertise, because imagine the surgeon is going in and encountering all this devastation in the valve with fistulation, perforation, and abscess formation. So it isn't an easy job. So it's a difficult task. And we said that surgery basically is indicated if the patient has heart failure. So if the patient develops heart failure as a consequence of infective endocarditis because it destroys the valve, I think this is indication for emergency surgery, okay, or urgent surgery. But if there is an abscess formation, fistula formation, and sometimes if there is also resistant infective endocarditis which fails to be treated on antibiotic, you might go surgical, okay. But the periannular extension of the infection, tilts the balance towards surgery. And actually, in the guidelines, there is an inclination to advocate early surgery than late. Earlier is better than late. Okay. Now, what are the indications for prophylaxis? First of all, prophylaxis of infective endocarditis is which class in the guidelines? Class what? 1, class 2, or? What's the class of recommendation?
Class 2A.
2A or 2B? And I'm not sure about whether it's A or B, but I'm sure it's, like you said, it's class 2. I don't know if it's A or B, but it's class 2. Class 2 means what? It means it's reasonable. But it's not, it should. It should is class 1. You shouldn't is class 3. 2, it's reasonable if it's class 2A, and it may be reasonable if it's class 2B. So there is no obligation. There is no kind of mandatory stuff it's reasonable. And you know, even that's a kind of downgrade, because earlier on it was a stronger recommendation than this one, but due to the lack of evidence as to the advantages of prophylaxis, they downgraded the evidence to class 2. Okay, because they found out that it's not about the work, dental work and stuff like that. Even with toothbrushing and flossing and all of this, you have bacteremia. So what are you gonna do? Are you gonna give patient prophylaxis with each morning he's brushing his teeth and stuff? So there is no evidence, you know, there is no substantial evidence as to the advantageous role of prophylaxis. That's why they downgraded to class 2. And not only that, but they have restricted the conditions in which you need prophylaxis for only 4 or 5, which are
congenital heart disease, prosthetic valve,
metallic, or bioprosthesis. Okay, and
previous endocarditis.
Very good. Previous infective endocarditis. And 4, heart transplant. Okay, heart transplantation. Yes. So infective endocarditis, prior infective endocarditis, prosthetic valve, heart transplant, and congenital heart disease. But congenital heart disease, we have to talk about it because it's not just like generalization. Cyanotic heart disease or repaired cyanotic heart disease corrected with residual shunt. If they are corrected by devices, surgical or percutaneous, and there is residual shunt, meaning that you have to give. Or if they are corrected, but it's still within less than 6 months of this correction, during this period, they may be on antibiotic prophylaxis. Why is that? Because the initial 6 months after correction by devices, for example, there is no yet full endothelialization. So these devices are still a nidus of infection. Like after 6 months, most likely they get endothelialized and buried into the wall, so they are not a source of a problem anymore, unless there is a shunt. If there is a shunt, problem exists. Okay, so when we are talking about congenital heart disease, we are talking about either cyanotic heart disease or corrected one with residual shunt or less than 6 months after correction. Okay.
Okay.
Good. Now, can somebody tell me what is he or she seeing? Just a guess. You see, this is a transesophageal echo. You see, this is the mitral valve, this is the aortic root, and this is the aortic valve, okay? And in fact, the aortic valve is bioprosthetic. It's bioprosthetic aortic valve. You see the shadows here? These are acoustic shadows because of the prosthesis. Now we are seeing a mass, you know, originating from the undersurface of the valve and flapping into the LVOT. So this is vegetation. This is typical of vegetation. We also can see this cavity, and you see this cavity is where? It is between the aorta and mitral, which is the area we have described before as the intervalvular fibrosa, which is the area of abscess formation. So this is abscess. You see this cavity? This is an abscess. I see how nasty looking it is, and sometimes it can break off, you know, and rupture, leading to fistula. You know, this fistula can be between the aorta and the mitral, and the patient might go into heart failure because of that. Okay, So this is the abscess. Good. Vegetation with abscess. Good. Now, this is a question to you. Thrombus formation has a predilection to this structure, which is called LA appendage. So this is the left atrium, the mitral valve with the anterior leaflet and the posterior leaflet, and the LA appendage here. The interatrial septum is here. The aorta is somewhere anteriorly, and tricuspid valve is here. So this is the LA appendage. So the question is that thrombus formation has a predilection to this structure. Why? Because it's a vestigial structure. Emptying is more dependent on atrial contraction than LA cavity. It is more rigid than LA cavity. It shows a smoke sign, which is dense, spontaneous echo contrast under physiological condition of blood flow. So which one you think is right?
B.
B. Okay, great. Any other thoughts?
A.
B?
No.
Yeah, by the way, this LA appendage, is it just a vestigial structure, functionless part of the left atrium, or it has a function? Does it have a function? And once actually I read a topic about LA appendage. It was entitled LA appendage, useless or priceless, because after the inception of the LA appendage occluder devices, this gave them
usually the risk of thrombus formation in LA.
Yes. I think just the sound is velocity. So you think it's about velocity? Yes, I agree with you. I agree with you. I want you to confirm for me again if my sound is steady or not, any kind of crack is interrupted. Is my sound fine?
Yes, it's fine.
Okay, great. Good. So we said initially, let's talk about whether this LA appendage is useless or priceless. Is it functional organ or part, or it's functionless? It is functional part. It's functional part. How it functions? Histologically, the LA appendage has more elasticity because of its tissue than the LA cavity. Okay, so it expands and dilates under pressure more than the left atrium does. And that means what? The LA appendage works as a venting mechanism. It vents the LA pressure by the dilatation and stuff like that. So if you occlude the LA appendage percutaneously or surgery, probably you are going to sacrifice this venting mechanism, and the LA pressure might go high. Yeah. So that's a real problem, and I think the jury is still out to decide about the late ramification and consequences of LA appendage occlusion. So I don't think we have to take it leniently that if we occlude the LA appendage, things are fine. It might not, you know, because it's functional part. Now, in atrial fibrillation, almost 98% of thrombi forms in the LA appendage. And like you said correctly, it's because of flow differences. Let's see what flow differences are there. You see the mitral inflow. This is the normal physiological mitral inflow. It has an E and A. E is the initial flow, which is passive emptying, and A is consequent to the atrial contraction. Okay. Now, let's see the LA appendage. Look at this flow. What is this flow? This is the flow that corresponds to atrial contraction. Atrial contraction. So where is the passive flow? Where is it? Where is the passive flow? Are you seeing it? Right. I'm gonna show you this to see it well. Right. Look here. This is the LA contraction flow. You see, it's this one, which is immediately after the P wave. Okay, immediately after the P wave. Now there is this flow and this flow, which are systolic flow. They call it systolic oscillation, they call it whatever, but this flow, you see a small flow here. This one is the early diastolic flow, which is the passive emptying. So look at the passive emptying from the LA appendage, this much. Look at the atrial contraction flow, this much. Compare it to the mitral inflow. The initial flow is big deal. The atrial contraction is not that much. So we are talking about 70, 30, 80, 20%, and we are talking about the reverse in LA appendage. So LA appendage is more dependent on atrial contraction for emptying than the left atrial cavity. That's why when we lose the atrial contraction in AF, we lose a lot. The LA appendage loses a lot, but the left atrium cavity doesn't lose a lot. It loses this one, which is 20–30% of the emptying. But the LA appendage loses 80–90% of the emptying if the atrial kit is lost. That's why it's more susceptible to stagnation when we lose this atrial contraction than the LA cavity. That's why thrombi forms in the LA cavity more than the mitral, more than the LA cavity, in LA appendage cavity than LA proper cavity. At least that's a contributing factor. There might be other factors contributing to this, okay? But I wish you understand the flow differences between the LA appendage and the left atrial cavity, okay? You get this difference?
Yes, it is wonderful.
Very good, very good. Now, see here, we have this patient who is referred to us. He had atrial fibrillation and he came with a stroke. First of all, my question, is TE indicated in this patient? AF with a stroke.
Yes. If
Why?
if the transthoracic is did reveal the cause of stroke, how it didn't reveal the clot.
But I remind you, this patient is atrial fibrillation. So he had a cardioembolic source already.
Yeah.
So why are we looking any further? As per the guideline, I think I mean, TE wasn't necessary in this patient, okay? Wasn't actually indicated because you do TE when you are looking for cardioembolic source and you need so much to do enough scrutiny But once you have atrial fibrillation, that means the patient is having cardioembolic source. Like in our colleague in neurology, I don't know, they lower the bar for T indication, and they are requesting a lot of Ts nowadays for stroke patients. And they think that AF, if I have AF with a clean LA appendage, I might not necessarily anticoagulate, because you know stroke sometimes can be massive and can be pre-hemorrhagic. So if they give anticoagulation, there might be hemorrhagic transformation. So they need to know exactly the risk and benefit ratio between giving anticoagulation or holding anticoagulation. So if there is an LA appendix thrombus already there, that tilts the balance towards giving anticoagulation regardless of the hemorrhagic risk. But if the LA appendage is clean, they say we may do without anticoagulation, at least for a while. I'm not sure about this, but that's the kind of deliberation we go with them daily. Anyhow, this patient, we did the TEE. And look at the LA appendage. What do you see in the LA appendage?
Full of clot.
Yes, exactly. Full of clots. I like this expression because it wasn't one. Actually, we have identified kind of a composite one, which is having 3 components. Okay, and you see the left atrium, we scan the left atrium, we find nothing. It's all the thrombi are all in the LA appendage. Okay, so this is LA appendix thrombus and how it looks in transesophageal echo. You might have also appreciated that the mitral valve is severely degenerative and calcified. You see the calcification here. This is MAC, mitral annular calcification, and you also have calcification on the anterior leaflet. Okay, good. Now I'm taking you to the next case of a 55-year-old lady. She had metallic mitral valve replacement 3 years ago. She presented with chest pain, shortness of breath, ST depression in precordial leads, and her troponin was 0.2. So, can anybody describe the echo?
She had the global hypokinesis.
Okay, if you look here, yeah, I would go with you. That is kind of global. But look here, in the epical 4.
There's some of regionality.
Yes, regionality, because you see, this is the lateral wall, the apex, and the inferior septum. So you look at the lateral wall, probably the basal lateral wall and even part of the mid are contracting. But down, no, the apex is not. And even the inferior septum, it's, you know, the mid downward. But the basal inferior septum is probably contracting well. Okay. So what do you think the problem with this patient? Presenting acutely with chest pain, shortness of breath, ST depression, and troponin is 0.2. What's the best next course of action? What are you gonna do here? Wait and see, take for cath lab, think of further workup. Okay. So I think, what's your thought about this one? Because, you know, when we talk about regionality, that means ischemia. And the patient presented with chest pain, ST depression, elevated troponin. So I think we should deal with this patient as acute coronary syndrome, non-ischemic, okay? And should be taken to cath lab, right? You agree with that?
Yes.
Yes.
Yeah, exactly. And just to bring your attention to this mitral valve. You see the mitral valve is metallic mitral valve. This is how it looks like, metallic mitral valve. So we have a patient here with chest pain, ECG changes, elevated troponin, and regionality. So I think we should go for cath. Okay. Now, I tell you the story of this patient because this patient is mine, and she was admitted with this presentation, and I booked her for CAS, but unfortunately, next morning, there was a problem. There was like big traffic in the cath lab, so they delayed this case and they asked me, book her for the next day. So I said, you know what, because I was suspecting Takotsubo in this patient, and so I said, let me do echo again. I have done her echo upon admission, and then next day, I did echo next day. And believe it or not, if we say that the ejection fraction here is like what? It's like 25%. You see the ejection fraction is severely impaired. Actually, I mean, the LV function is severely impaired. Next morning, her ejection fraction is 45-50. Okay? So all these regionalities disappear to a large extent. Next morning, just 24 hours after this ECG. So shall I stop and say, خلاص, I confirmed Takotsubo? I don't know, but I took her to catch up. even though the probability of infective the probability of Takotsubo is really high after nearly normalizing echo next morning. But because, I don't know what to do here, I took her to cath lab and normal coronaries. Okay, because so far the diagnosis of Takotsubo is stress-induced cardiomyopathy is a diagnosis in retrospect after you rule out ischemia, invasively or non-invasively. Okay, but you have to rule out ischemia. Okay, good. I want to show you something here. You see this one here, the RV. This is the RV, right?
Yes.
And this is the RV at the apical segment. Look at the RV at the base, mid, and apex. What do you think? What do you think? It is more active at the base than at the apex. You see, the apex of the RV is severely hypokinetic. Compare this part of the RV to the basal part of the RV. So what is this? This is RV apical hypokinesis. An RV apical hypokinesis in many studies is consistent with diagnosis of stress-induced cardiomyopathy. They think that having RV apical hypokinesis increases the probability of increases the probability of Takotsubo really a lot. يعني the diagnostic certainty of Takotsubo increases a lot if you elicit RV apical hypokinesis. Okay, if you have ischemia, with aneurysmal apex, most likely the RV apex is spared. It's going to be contracting normally most of the time. That's what we are seeing. But with Takotsubo, somehow the RV apex is affected and it goes hypokinetic. So if you demonstrate this sign, that increases the diagnostic probability of Takotsubo. But remind you, there is no way so far to diagnose Takotsubo confidently before you rule out coronary artery disease. So the recommendation is to go for ruling out ischemia, invasively or non-invasively, before you diagnose stress-induced cardiomyopathy. Maybe in the future, we are going to have a prospective way of diagnosing Takotsubo, and we can have diagnostic signs upon which we can rest our diagnosis about stress-induced cardiomyopathy confidently, and we can do without cath or coronary angio. But so far, no, we have to do coronary angio, or at least non-invasive testing for ischemia. But we have to rule out ischemia. Okay. So that was a case of stress-induced cardiomyopathy, Takotsubo. Any question here?
Sorry, I have a question. In cardiomyopathy, dialytic cardiomyopathy, DCM, we get same picture like this. Yani we get epical RV hypokinesia.
No, no. In first you ask an interesting question. Just let me show you here. If you have, let's say, ischemic cardiomyopathy, that could be ischemic cardiomyopathy with aneurysmal epics. That epics is aneurysmal. Most likely, if you have ischemic cardiomyopathy, it's gonna affect the LV and not the RV. The RV will remain intact. Now, if you have non-ischemic cardiomyopathy, dilated cardiomyopathy, the RV may and may not be involved. But if it's involved, it's going to be involved globally. There will be global RV dysfunction, not regional, like the one I'm describing now. I'm describing a regional wall motion abnormality in which the apex is hypo and the free wall is normal. That is Takotsubo. So in DCM, you either have a normal contracting RV or globally hypokinetic RV, but not regional. The only two conditions I'm aware of that leads to segmental wall motion abnormality in the RV are two: Takotsubo and
BE.
what else?
BE.
Yes.
The corner side.
Thank you so much. PE leads to the opposite of what Takotsubo does, which is we are going to have epical sparing hypokinesis, meaning the RV apex is contracting or hypercontracting, but the RV free wall is hypokinetic. In Takotsubo, we have the opposite. We have epical hypokinesis and the free wall is contracted. Okay? Good?
Thank you.
Okay. Now, this is a 41-year-old man with chest pain. So, what are the characteristics of chest pain in this patient after reading the ECG?
Most probably pain of pericarditis.
Yes, exactly. So you said pericarditis because of?
PR depression and scheduled segment.
Yes, very good. PR depression, which is most specific of pericarditis, the PR sagging or PR depression. And we also have ST segment elevation, concave morphology. We also have PR elevation in AVR. Okay, you see PR elevation in AVR and PR depression in other leads, along with the concave morphology of ST segment elevation. So this is pericarditis. So tell me about the characteristic of pericarditic chest pain.
Retrosternal pain, increased by lying down.
Okay.
Relief when the patient leaning forward.
Okay.
May be associated with breathing, inspiration.
Okay, great. So it is positional respirophasic pain. With inspiration, it increases. With lying flat, it increases. Okay. And with cough also, it increases. Okay. Good. Yeah. Now, what other history data has bearing on the management? Now, if you see such patient, what question are you gonna ask for?
I would like to ask about the underlying cause of pericarditis.
Oh, great. Like?
Past history of upper respiratory tract infection.
Very good. And
history of uremia.
Okay, great.
ischemic heart disease recently.
Yes. Okay.
Possible cause. Thyroid disease.
Okay. Connective tissue diseases.
Yes, connective tissue disease.
Okay. Trauma.
Yeah.
Trauma. Yeah. Okay. And if the patient is in an immunocompromised, I mean, chemotherapeutic agent, immunocompromising medication, these are important. Okay. Now, what are the expected clinical signs?
May find pericardial rub.
Yes, you may and may not find pericardial rub. Yeah, pericardial rub is friction sound, okay, because of the inflamed pericardial layers, and when they get rubbed against each other, that produces a sound that could be picked by the clinician. Yes, but sometimes when you get pericardial effusion already, it's going to separate the two layers, and the friction will dampen or gets eliminated. So that is going to soften the friction rub, or you won't hear it anymore. Okay, so don't feel frustrated if you couldn't appreciate friction rub. Okay. Now, what lab and imaging data you would like to obtain, if any? And you might say, I don't need anything.
Yes, may not need anything. I mean, the lab investigation is guided by the history.
Oh, yes, good.
And we need echocardiography,
Okay.
plus or minus CT.
Plus or minus?
CT.
Why CT?
To look for, sometimes we need to look for calcification, to assess.
Okay. Yeah, I agree with you. About sometimes, constrictive pericarditis might have been preceded by subtle pericarditis, but I think if you are dealing with acute pericarditis, maybe you don't have to think of constriction now. Acute pericarditis is most likely a benign condition, and in the vast majority of patients, it resolves either spontaneously or a medical therapy without any residual damage. Okay. For what we usually need to decide about whether to keep an eye on this patient or send him home is no large pericardial effusion and no leaking troponin. So I probably need echo and troponin. Echo to rule out large pericardial effusion, and TNT or troponin to rule out what? The myocarditis, which might be associated with pericarditis. In this case, we are going to call it myopericarditis. So the patient might present with inflammation of the muscle and the pericardium. So what you are seeing in ECG is the pericarditis, but from the lab, you are going to see the myocarditis. And in this case, if I have a patient of myopericarditis, because his ECG is pericarditis and his troponin is elevated, most likely I'm going to admit this patient and keep him under observation. Okay.
Okay.
So these are the indications for admission. Usually, if you have troponin elevation, you have large pericardial effusion, or traumatic kind of pericarditis, patient who are immunocompromised, even if the pericarditis is associated with fever, you have to admit these patients. So there are criteria for admission, and there is a scoring system, That's why pericarditis, you don't admit all patients, but you don't send all patients home. So it's a matter of clinical analysis, imaging data, lab data, and, have to think and analyze and see where your patient is. Now, what medication I'm going to give this patient? pericarditis.
Non-steroidal plus colchicine.
Yes, non-steroidal plus colchicine. Non-steroidal plus minus colchicine. And sometimes if you give non-steroidal for 2 weeks, that's all you need. لكن we prefer to combine non-steroidal with colchicine. And if we start colchicine in studies has shown better improvement and prevent the recurrence. So colchicine is given, I think, 0.5 milligram twice daily for how long? For 3 months. So colchicine is given for 3 months. It's a long time, actually. Now, what are the indication of steroids? Steroid is usually not given, okay, unless there is resistance to the first-line medication, which are non-steroidal and colchicine, okay? Yeah, so steroids should be avoided unless you have to. Good. Now, let's see this ECG. Can somebody describe this ECG? You see what?
ST segment elevation in the inferior leads.
Very good. So we have ST segment elevation in the inferior wave. What else?
ST segment depression in V1, V2, V3.
Yes, exactly. Here.
And diffuse T wave inversion.
Okay. Okay, good. So, what's your diagnosis here?
Inferior STEMI with posterior extension, possibly.
Yeah, most likely there is posterior extension because you see here, especially in V2, I have dominant R and ST depression and upright T. So these are mirror change of ST elevation in V2. So probably I have posterior extension. Okay. Now, the inferior wall MI, always you have to look for blocks like first degree, second degree, third degree, and for the posterior extension. And better to do what? If I want to confirm if I have posterior extension or not.
Posterior on right side.
Exactly. Yes. So I think, you know, if we make it a routine, I don't know, it will be better, but I don't know. It's not recommended to be a routine. Doing posterior leads and RV lead. Okay. So we are taking these leads and putting them posteriorly in the back. In this case, you are gonna see ST segment elevation, not the mirror changes. You are gonna see actually STEMI if there is posterior MI. And also if you are suspecting RV infarction, because the RV is not represented in this ECG, because RV is the right structure. V1 is the closest to the right side, to the RV, but V1, 2, 3, and 4 is overlying the LV. So the RV is underrepresented in the ECG. So if you want to have your ECG looking at the RV, you do RV leads. So you place these leads instead of V1, V2 on the lateral side, left lateral, on the right lateral. Okay. In this case, if there is RV infarction, you are going to see ST segment elevation. Okay. Good. So this is how you diagnose RV infarction and posterior infarction, by placing the lead non-conventionally. Now, what are the ECG prognostic features when you are diagnosing STEMI? Whenever you see STEMI in general, not only inferior, what are the other data in ECG that you gather in prognostication?
I think the presence of tachycardia or
Very good.
bradycardia.
Thank you so much. So tachycardia is important, you know, the TIMI risk score for MI tachycardia is 1, along with hypotension, clip class, and so. So tachycardia, whether sinus or otherwise, tachycardia is grave prognosis. Okay. What else? Blocks. First degree, second degree, third degree, right bundle branch block, left bundle branch block. These blocks indicates more extensive infarction, more extensive myocardial damage. Okay. Especially if you compare these changes against the baseline, which was not showing these changes. And if the patient is having, let's say, left bundle and now left bundle, that wouldn't be a problem, right? But if he has no left bundle, now left bundle, that's big deal. Patient has, let's say, no baseline first degree heart block, but now first degree heart block with MI. So that means a lot. Okay. So comparing the ECG now with old ECGs sometimes is essential. Now, what else? Prognostic.
Poor R wave progression.
Yeah, poor R wave progression is equivalent to Q wave in the precordial leads. Okay, so if you have poor R wave progression, probably you might have kind of extensive myocardial involvement with scarring tissue and stuff like that. What else?
Q wave.
Qs is about time more than the extent of damage. And it tells you that you are probably late, but I don't think it imposes a particular prognostic value, huh?
Arrhythmias?
Like what?
Ventricular arrhythmia, BTAC or VF?
Of course, and if the patient presented in VTAC or VFib, that's a gloomy kind of prognosis. But even if you see BVCs, if a patient is having STEMI with frequent BVCs, that's not good news. Okay, good. What else? The extent.
Inappropriate tachycardia.
Tachycardia, yes, we said tachycardia is important, yes. And what about the ST segment elevation itself? Does it mean anything? Yani how much of ST segment elevation? If I have ST segment elevation of 2 millimeter versus 5 millimeter, does it count?
Yeah.
Yes.
Yeah.
Yes.
So
the tombstone is carried by poor.
Yes. Very good. Tombstoning. The more of ST elevation, the poorer the prognosis. So the more it goes up, the lesser the outcome. Or the poorer the outcome. Okay? Good. So what is the role of troponin now? Troponin. Is it important?
For prognostication.
Yeah. Troponin is important for diagnostication and prognostication, because it helps you in the diagnosis of STEMI, and also the amount of elevation or how much troponin is elevated is prognostic. And if I have this STEMI with troponin of 0.2, it's not like the same STEMI with troponin is starting with 4. The more of troponin, the more of myocardial damage, myocardial injury. Okay, so troponin reflect the amount of injury, so it's very prognostic. It's very prognostic. Now, what is the role of echo? Do you need echo for STEMI diagnosis? Please say no. Please say no.
No.
No. Yes. No. Unless in very specific controversial cases. only specific controversial cases. Like you are not sure if this is segment elevation or not. Is it pericarditis or STEMI? I don't know. Is it an old aneurysmal epics, you know, or something new? Is it left bundle? I don't know if it's new or old. But if I see the echo, it might help. يبقى الإيكو يا إخواننا عنده limited utility in the acute setting of okay? In only controversial cases. Now, you are probably doing a lot of exercise ECG, and that's what you get usually. I'm gonna just show you this is better. Okay, you see this when we talk about ST segment depression, what are we actually talking about? See, this is the ST segment. The ST segment is start from the S wave, which is here, to the T wave. That's called the ST segment. So the ST segment is from the S until the end of T. But usually what we are focusing on when we talk about ST segment shift is this part from the S to the beginning of the T wave. How it is shifted. When we talk about, now you are a cardiologist, so you can or you should describe ST segment depression more elaboratively. I love to hear you describing it in terms of morphology and degree and extent. So the ST segment depression has to be described in 3 terms. The terms of extent, how many leads are involved. The term of extent, how many millimeters the ST is going down. And the term of morphology. Morphology is like this one here. This is called episloping. You see, it is depressed, but depressed in an episloping fashion. If you compare it with this one, it is horizontal. Horizontal. Compare it with this one is down sloping. You know, so I have episloping, horizontal, down sloping. Okay, so these are different morphologies. So in terms of specificity for ischemia, which one is the most specific of ischemia in these 3 types?
Down slope.
Which one? The down sloping, exactly. This one, followed by
horizontal.
Very good. And last and least is this one, the episloping. Okay, so يلا معناته يا اخواننا الان whenever you go to the exercise lab, please describe the ST segment depression in terms of how much, how many millimeters. I am gonna check how many millimeters from here down to the deepest part. How many leads are involved, and whether it's horizontal, down sloping, or up sloping. Because if you tell me it's down sloping, I'm more confident of ischemia than when you say it's up sloping. Because up sloping sometimes could be just a normal physiological response to exercise. It goes down in this morphology. So the specificity for ischemia here is low, not like in here. Now, sometimes during exercise testing, you might get ST segment elevation like this one, and I wish you don't. And this is the most alarming during exercise test to get ST segment elevation. But before you shout out loud, look at the preceding QRS complexes. This is important. If it is Q-bearing lead, ST segment elevation, no big deal. But if it's upright complex and no Q wave, that's big deal. That is actually STEM. You get this point? You get this point?
معلش يا دكتور حاتم ممكن
يعني دقيقة كده لأنها دي مهمة. If I have ST segment elevation during exercise testing, just quick analysis, quick few seconds analysis. Do you have it like this, Q wave and ST segment elevation like this, or you have like this, R wave and ST segment elevation? If you have it like this one, no problem. If you have it like this one, activate the cath lab or do the necessary measures as a STEMI. This is a STEMI, but this one is not a STEMI. So if the leads that shows the ST segment elevation, they already have Q waves at baseline, ST segment elevation is kind of normal response. Because Q wave indicates what? Q wave indicates, most likely you have scar tissue, dead tissue, necrotic tissue, old myocardial infarction. So with the exercise, it goes under restriction, tension, and it gets elevated. So that does not mean I have new insult. This is the same old insult expressed in a different way. But if I have an upright complex like this without Q wave and I get ST segment elevation during exercise, that's systemic. That's systemic. Okay. In this case, you are gonna shout out loud for help in this case, but not in this case. Okay. Now, sometimes you can see Q wave, U wave. You see this one? This is a U wave. And if U wave get inverted during exercise, but that needs a lot of focus because with the tachycardia, you fail to appreciate the U wave, let alone the inversion of them. But if you appreciate U wave inversion during exercise, what does that mean? It is very significant change. You should report in bold red letters because that indicates left main proximal LAD. If you have inversion in the U wave, يعني معناتها exercise ECG يا اخوان, it's not about the ST segment depression. حتى ال ST segment depression has to be described elaboratively. Then you also have to look at the U wave. ممكن مرات تكون في changes ثانية. ال U wave is very significant if you could appreciate. حصل U wave inversion, that's big deal. وتكلمنا عن ال ST segment depression, how significant it can be and how not significant it is. Okay? يبقى ال ECG في الاكسرسايز لاب شوية محتاج مننا يعني مراجعة. Now, what is the treadmill score? لما نتكلم عن treadmill score, what do we mean by that? Are you using treadmill score? ولا؟ طيب. A treadmill score, sorry, is my sound clear?
Yes.
Yeah. A treadmill score is this one. Exercise duration in minutes, in Bruce protocol, -5 times the ST segment deviation in millimeter, -4 times the angina index. And what is the angina index? Angina index is 0 if no angina during the exercise. It is 1 if there is angina, but it's not limiting the exercise, meaning the patient has chest pain, but he can carry on the exercise. Now, it is 2 if it stops the test. Yani if the angina is severe enough to terminate the test, that is 2. So this is what you are gonna do here. Okay. So if a patient exercised, let's say for 10 minutes, and he had 2 millimeter ST segment depression, that will be 10 here. And he had exercise limiting angina, so that will be 8 here. So it will be 10 minus 10 minus 8. So what is this? 10 minus 10 minus 8, it is minus 8, right? Minus 8. What's the meaning of minus 8? What's the meaning of minus 8? It is somewhere here in the middle. So if it is minus 11, the mortality is more than 5. If it is plus 5 and more, the mortality is 0.5. So we have high risk, low risk, and intermediate risk according to the treadmill score. So treadmill score is very, very prognostic, and it incorporates 3 parameters: exercise duration, ST segment deviation, and angina index. And this is how you calculate it. Okay, so it's important. It is important. Okay, it is important. Important حتى لأي درجة. الآن if I ask you which one of these 3 are the most important, and this is a common question in the exam, what is the most prognostic measure in exercise testing?
Patient symptom.
No,
Angina index.
no,
ST segment deviation.
no. These are all prognostic, but the most important prognostic.
Duration.
Duration of exercise. Duration of exercise. How much the patient exercise. يعني if a patient هنا exercise for 20 minutes and he gets whatever he gets in here, no problem. It's not like a patient who exercises for 5 minutes and gets nothing here and nothing here. So exercise duration is paramount. The most prognostic parameter in exercise ECG is the physical capacity, is the functional capacity, how much the patient can exercise. Then the ST segment depression, then the angina score, then the rest of the parameters. Okay, good. Now I have this one, echo of a 32-year-old male who experienced unexplained syncope twice. Otherwise, the patient has good functional capacity. What is the best course of action at this stage? Beta blocker, septal myomectomy, secondary prevention of VTAC, or cardiac MRI? If you see the echo here, you could appreciate that the septum is thick. I think it was 1.6, and it is asymmetrical septal hypertrophy because the septal thickness is more than the posterior wall thickness. If you focus attentively, you could appreciate some, you know, the anterior leaflet is flying in systole towards the LVOT. And look at the flow acceleration here. Yes, the flow acceleration, if this is the aortic valve is here, where is the flow acceleration? Turbulence in is in the LVOT. That means I have LVOT obstruction. And the Doppler has confirmed that by showing the dagger shape with a high gradient. So I have a dynamic obstruction. So this patient is having HUCM, hypertrophic obstructive cardiomyopathy. Now, what I'm going to do for this patient? He experienced syncope twice, unexplained, meaning it wasn't explained. Yani if he had syncope because of dehydration, that is explained syncope. If he had hypoglycemia and he went dizzy and lost consciousness, that's explained syncope. But in this patient, we have unexplained syncope. Unexplained syncope, على طول you connect it to what you see in echo. So this is HUCM-related syncope. If I have HUCM-related syncope, am I going to give this patient beta blocker, or septal myomectomy, or secondary prevention of VTAC, or CMR?
See? Secondary prevention.
Secondary prevention of this. And this is the right answer. Exactly. So syncope is considered to be arrhythmogenic in HOOCM. So once I have unexplained syncope, I'm going to assume that this is arrhythmogenic HOOCM-induced syncope. And in this case, I have to go for ICD. For ICD. So I wish so much إنه دائما الهوكم تقسموه إلى two, you divide it into two problems. HOOCM has two main clinical routes. Okay. One is symptoms of shortness of breath. Symptoms. And the other thing is prognosis. Prognosis relates to what? To arrhythmogenic problem. So we have prognosis and symptoms. If the patient is having shortness of breath, effort intolerance, these kind of stuff are dealt with by medication and septal ablation. But if I have syncope, VTAC, previous cardiac arrest, family history of sudden cardiac death, these are prognosis and I go for ICD. So I'm going to select my patient properly. Is this a patient for ICD or a patient for medication or septal myomectomy? Septal myomectomy is symptoms. ICD for prognosis. So what are the prognostic markers for ICD? اللي هي بنسميهم high risk features for sudden cardiac death. What are they? One is a patient, you demonstrate VTAC in Holter. Two, unexplained syncope like this one or sudden cardiac arrest. Three, family history of sudden cardiac death. Family history. Four, septal thickness. If this thickness is big, like big is 3 centimeters. If the septal hypertrophy is 3 centimeters, that's a problem. If I have, these are the conventional. Now in the new guideline, they have added 2 more or 3 more. They have added the ejection fraction less than 50, because usually in HOOCM, the ejection fraction is approaching 100% actually. Because you know it's a strong heart because of muscle. So if the ejection fraction is lower than 50, that is prognostic. Or if there is epical aneurysm. Why there is epical aneurysm? لما يا اخوانا يكون في obstruction في ال LVOT ولا في الميد cavity, that sometimes lead to pulsion aneurysm. Pulsion, you know the Zenker aneurysm of the esophagus, اللي هو it's sort of traction aneurysm because of pressure. لما البريشر تكون عالية في الميد كافيتي ولا ال LVOT, the apex might bulge out. So epical aneurysm is prognostic. And last is the CMR. You do cardiac MRI for delayed hyperenhancement to assess the amount of scarring and fibrosis. If scarring involves more than 15% of the entire myocardium, that is prognostic. So now we are using CMR as well. So we have Holter feature, clinical feature, echo feature, MRI feature. And we have a scoring system, then you decide about to go for ICD or not. Lakin Anna, I wish you know these factors, I mean, high risk features by heart. The clinical one, the ECG one, the Holter ones, the imaging ones, you know, you have to. This is prognosis. So this patient was having syncope that puts him in the prognosis category, and I will go for ICD. If the patient is symptomatic, he has shortness of breath, I will go for beta blocker. If beta blocker fails, I might consider septal myomectomy. So beta blocker and septal myomectomy for symptoms alleviation. ICD is for sudden cardiac death. So HOOCAM has two clinical tracks, always. Okay, good. I think we are going to stop here. Okay. Probably next week there will be coronary angiogram session. So we might continue on this session some other time. Like next week, hopeful in our session is going to be about coronary angiogram with interventionist. So do you have any questions? Any questions?
Thank you, Dr. Hatim. Very interesting talk today.
Thank you so much. Thank you. Thank you so much. And hopefully I just cover quick kind of stuff. Like I assure you, we are going to go deeply in each and every topic we have discussed today. But don't worry, we're going to repeat and repeat and repeat until we consolidate the most essential data in our mind.